Hi, I'm Dr. Lisa Allen from BioMechanic Physical Therapy. I'm here today to introduce a new lecture series that we're offering both live in the clinic and here on YouTube. If you'd like to see one live, please check our website for upcoming dates. Our first lecture is Dr. Sarah Donahue discussing knee pain.
So welcome, thanks for coming. This is our second seminar in the series that we're doing this summer. This one is about knee pain. So I hope everyone has had a chance to kind of think about your own knees or someone that you know and love. And hopefully we can have some answers to some of your questions that you have about pain that you've been having or have had or hope to not have ever. Okay, I'm Sarah Donahue. I'm the Director of Physical Therapy here at BioMechanic PT. Our practice has been open almost 10 years, and we have a wonderful staff that I'd like to show you a few photos of before we get going. There's 6 therapists, and we have some techs, and front desk staff, and billing, and marketing, and we all love working here, working with our patients. Of course, the patients are what makes the world go round for us at BioMechanic. So we like to have lots of fun and make it interesting, even though you're coming in to see us with pain. Hopefully you have a fun experience. I think some of you already have experienced us a little bit. So, to dive right into things, this is a very jam-packed slide full of different types of things that can cause knee pain. So I don't want to get too scary right off the bat, but this is kind of an outline of everything that we're going to go over this evening. All the various causes of knee pain. It can come from any of the structures that are in your knee, and knee pain can actually come from other areas too. So the cartilage, mechanics of your joint, and the muscles and all the levers and pulleys that need to happen, the ligaments that hold everything together, and then the muscles that are your power. They can all cause pain. But then we have these other things, tendons that attach the muscle to the bone, the bursa that are supposed to be nice fluid-filled sacs that allow things to glide smoothly. All of those different structures can cause their own different types of knee pain. Okay. We're going to talk about how each one produces a different type of pain, a different location of pain, a different way that you injure the area. So don't worry too much about this because we're going to go individually, but just start thinking about where you have your knee pain. So I'm going to ask everybody to kind of think in x-ray vision now. Okay, this first picture that we see here is a drawing of what the anatomy of a knee looks like. Okay, we've got your femur and your tibia. Those are the 2 main bones. The fibula is here hanging out on the side too, and it doesn't do so much when you're walking and moving around. You know, you can kind of live without your fibula, but when things start to go wrong with the fibula, it can cause pain on the outside of the knee. That mechanical kind of pain that every time you take a step, it just feels like something's not right, something isn't moving right. Okay? The other big bone of the knee that everybody knows about is their patella. Fun fact, little kids don't have patellas. Babies are born without them. They form inside of the quadriceps tendon around age 2. So I have a daughter who's going to be 2 in September, and I keep feeling for her little knee. Is it there yet? Does she have a patella forming? So, patellas are tricky because they cause all kinds of pain, from arthritis to tracking problems. You can strain the quad tendon that the patella pulls in. It's really a lever, and our bodies, are really amazing machinery, but when that one piece isn't working well, it can cause a lot of strain on the knee. So we're going to talk about that patella a little bit more too. But then you see the little white lines here, the tendons, and then on the side, in the middle, and on the other side, the little white lines that are ligaments. We have 4 major ligaments of the knee. And then we have these little green circle things that are menisci, the medial and lateral meniscus. So each knee has 2 menisci. And those are a very common injury that people have, meniscus tears, meniscus degeneration. So we have a whole section of the presentation to talk about that. But sometimes when you experience pain on the inside of the knee or pain on the outside of the knee, that's indicative of a meniscus tear. So this is just a nice little schematic of where is your pain. It helps us to know what's the cause. So when you come into physical therapy or you're talking to your doctor about knee pain, they're going to say, where is it? Where's your pain? Is it all the time? Is it only when you're walking? Is it when you first get up in the morning? All of that data doesn't seem that important to you, I mean, other than it's part of your life. But to us, that really, really can help us without an MRI, without x-rays, to determine where's your knee pain coming from. So it's really indicative of the severity of your injury and what the structures are that are causing it. So I hope that was a nice brief anatomy lesson. I didn't lose anybody already. But I can't help but mention that sometimes you have knee pain that isn't actually coming from your knee. And that's when things get a little tricky and we kind of put on our detective hats and we have to figure out, well, this doesn't really sound like mechanical knee pain. It doesn't sound like arthritis. Let's talk about your foot and ankle. Let's talk about your hip. Let's talk about your low back. All of these different areas can send referred pain or radiating pain down to the knee. You can see an image here of 2 trigger points that are up in the leg further. That those trigger points alone can cause knee pain. The little dots that come down are the area that you actually feel the pain. So sometimes our bodies aren't exactly right. They don't know. Your brain doesn't always know where that pain's coming from. But with the help of physical therapists, you're usually able to find out and get to the source of that pain. I love this picture. This is something that I illustrate all the time. One change in the mechanics changes everything all the way up the line. So here's a normal, healthy skeleton, and this is just bones. We're not talking about all those other structures here. You roll the foot in, and it causes the knee to go in. You turn the hip in, it causes the knee to go in. You rotate the back to one side, it causes the knee to go in on the opposite side. So this is something that mechanically we look at, and you can't just isolate and say, because my knee hurts, I need you to treat my knee. We look at the whole body and see where those different mechanical problems can be coming from. Okay, so to dive into each individual cause of knee pain and start talking about how we treat each one of them individually, I want to start first with just talking about knee instability. When we talk about an unstable knee, that's when those ligaments, those 4 ligaments, the ACL and the PCL in the middle of the knee, and the medial and lateral collateral ligament, MCL and LCL, that's when those get torn or stretched. This is the kind of injury where you're an athlete or an active person and you get a collision from the side, from the back, from the front. This could happen to you standing at the dog park, watching the dogs run around and then a dog just running into the side of your leg. It's my biggest fear at the dog park. It's my ACL. But there usually has to be a direct trauma. It can happen from just twisting your knee, but most of the time you have some sort of impact, okay? When you hear about a knee sprain, that's what this is. That's when those ligaments get stretched. And there's varying degrees of stretched out ligaments. A normal ligament looks nice and healthy. It doesn't have a lot of blood supply, so they kind of picture it here as being a white structure. When you have a grade 1 sprain, it stretches out. So imagine that rubber band, just a little stretchy. Maybe a few little pinhole tears throughout, okay? It never shrinks back down, or scar tissue may form. A grade 2 sprain is a larger tear, but it doesn't tear the whole way through the ligament. It stretches it and it starts tearing one side or the other. That's what's a grade 2 sprain. And then a complete tear would be called a grade 3. Now you always hear of athletes, ACL repair. A year from now they're going to be playing again. It's a long, long recovery. More and more they're treating ligamentous instability and sprains non-surgically. If you're a high-performance elite athlete, if you're a young kid who wants to go on to play, be active and do more sports, then yes, surgery is something that's usually fresh on the table for this. But a lot of knee instability can be treated with just strengthening up the knee. So even though your ligaments may never be the same, it's less trauma to not go through a surgery. You're able to strengthen, you gain body awareness, you go through the recovery, and you may never need surgery. You can live without an ACL. you can live without a PCL. And sometimes you can get those ends that have torn to kind of scar down, and it doesn't function 100% like a ligament, but it gives you much more stability than what you had with the small tear being there. Okay, so what can we do? We can, first of all, get the inflammation down. These folks might not put weight on their leg when it first happens, and they come in with this big ballooned up knee. We take care of the inflammation with massage, retrograde, ice, compression, elevation, all of that RICE stuff that you hear about. Rest and compression and elevation are so important, but it's only good for the first 48 hours or so. Then we move into the phase where things, we need to get things moving a little bit more. We start moving the ankle and foot. We start moving the actual knee so that it doesn't get stuck, bent, or stuck too straight. We're letting the tissue scar down, but we're also starting to build up strength. As soon as you have injury, pain, swelling in your knee, your quad muscle shuts off. It just stops working. No reason that we know of other than your body's own protective mechanisms, but this is something that your brain does automatically. So early physical therapy after an instability type of problem is encouraging that quad to start contracting again and teaching it. It's okay, it's okay, it's okay. Because that's what we have to do for our brains. The brain's in charge, so it's sometimes hard to override. Further on down the road, physical therapy, you're doing lunges and squats and practicing jogging and getting back to whatever activities that you want to do. But we're with you every step of the way to lead you through those type of things. So it always starts off with controlling the inflammation. And I'll talk to you about our little contest here later. Okay, any questions about instability? Okay. All right, the next cause of knee pain is mechanical pain. So this is a pretty big umbrella term. Mechanics can go wrong in any of the joint areas. Like we talked about the patella on the femur on the tibia, and then the tibia on the fibula, going up and down, if that helps with my representation of a knee. So when the patella is not gliding correctly, that's called patellofemoral pain syndrome. That's a very, very common diagnosis, especially for women. Women generally experience more patellofemoral pain syndrome because of our hip angle being a little bit wider and the knees coming inwards, as well as the decreased muscle bulk of the quad. They say, unfortunately for us, that a trained female has worse mechanics than an untrained male. And that's not always the case, but in a lot of cases, even an elite woman and a pretty out of shape guy, you can look at both of their knee mechanics and you can still see that the man might have better mechanics. So unfortunately, a little bit of discrimination there against us, but we know that it happens a lot of times in teenage girls, so early education and getting their hips strong, getting their foot into an orthotic if need be, and strengthening the muscles around the knee as they are out playing sports and whatever they want to do, trying to get that pain syndrome to decrease will help them down the road not turn into something like arthritis from the trauma of that repetitive stress. If you're already in the down the road, that's okay too. There's still hope. You can still strengthen the quad, you can still strengthen the hips, we can still look at orthotics. It's all the same treatments, it's just a little bit more of playing catch up than preventing the arthritis from happening in the first place. Okay, another common one, a lot of runners will get IT band syndrome. So again, it's a mechanical problem. It's an imbalance usually of one area being too tight and one area being too weak. And the leg, again, we're a machine. We need to function seamlessly. And if one little pulley is out of whack, then it changes all the stress on the joints. So the pain down the outside of the leg or the outside of the knee is what we call IT band syndrome, iliotibial band syndrome. Okay, so you hear this one a lot. Patellar tendonitis I talked about a little bit before. That's the pain right down here in the front of the knee. So the quad forms the patella tendon. The kneecap is inside of that patella tendon, and then it attaches right down here on the tibia. So a lot of knee pain patients might also have patellar tendonitis. If you have a knee replacement and you're recovering, you might get patella tendonitis. If you have an ACL tear and you're recovering, you might get patella tendonitis. That's because the added stress that happens down here instead of the quad muscle working. Okay, so that's one of the other issues that we're treating along with many other diagnoses. Finally, this is not an all-inclusive list, but I'm just covering the most common. But we have the pes anserine bursa. That's on the inside of the knee here. So you have your muscles that move your leg this way, come down and attach to the inside of the knee. There's a bursa here. Well, bursa is usually, imagine a balloon with a few drops of water inside and how smoothly that would slide on itself. Now imagine filling that balloon with a lot of water and kind of that bubbly, bouncy feeling. So when a tendon slides back and forth over that bursa and it causes a lot of friction, that bursa just fills up with fluid. And that's what bursitis is. And it's painful. You have the friction of that tendon now moving over a large balloon instead of a nice sliding mechanism. So that middle of the knee pain could be anything from the bursitis to the meniscus to a ligamentous issue. The quality of the pain, or pain when you squat or really blown up inside of the knee, can help us tell the difference. The mechanical problems are kind of a physical therapist's dream, because when you've had these mechanical problems start bothering you and we can start strengthening the weak and lengthening the tight muscles, we can fix these pretty easily. So if you catch these mechanical problems early and start to fix the issues, then you can prevent the injuries that I'm going to talk about next that are a little bit further down the road. Any questions about the mechanics? Okay. So we get into the big one, the meniscus tears. The meniscus is a fibrocartilage disc, and it helps the femur and the tibia kind of fit together nicely, like a puzzle. If you just set the bones on top of each other, they fit, but they don't really fit all of the contours. So these cartilage rings, they allow the knee to move smoothly and glide. They're kind of shiny and slick. So if you tear a meniscus by, it can be many things. Usually it's a pivot on a planted foot where you change directions suddenly. It can be walking the dog and getting yanked. It can be a fall. It can happen with a ligament tear, so you get hit on the side, and not only do you tear your MCL ligament, but you injure your lateral meniscus at the same time because of that crushing, pinching twist. And it can be any degree of tear. It can be a tiny little tear to a huge tear that takes a big chunk out of the meniscus. These tears have a lot in common, though, even if it's big or small. You will feel a popping, a locking, your knee might give way. You might have a lot of swelling right off the bat, and then you may, with a small tear, think, "Oh, I just tweaked my knee," but then a couple years later or a year later, do something very small and minor, and then the knee blows up again, and you're like, "What did I do? I didn't do anything. I injured my knee last year, but that shouldn't have any bearing on what's going on right now." Well, once you tear the meniscus, it doesn't heal. There's not much blood flow at all. So it may flap back down and appear to be lying smoothly, and then you twist again and it comes back up. So those types of tears tend to turn chronic, and you hear of people going in and getting scoped and getting cleaned out, where they take that frayed piece of meniscus away. Sometimes people will have a little piece of that meniscus floating around in their knee, and it'll get locked like you're shoving a wedge in a door hinge, and you feel like you can't really get that knee to bend. So all of these different things can be different manifestations of meniscus tears. This can down the road lead to more severe arthritis and kind of get into knee replacement territory. So it's kind of a slippery slope. But I can speak from experience. I've had a meniscus tear before. I was a kid, and I had surgery right off the bat. But if I knew what I knew now, I might have had a different plan for myself. Meniscus tears generally all come to therapy right off the bat. And you try therapy and try, and if then the outcomes still aren't good, if you're having a ton of pain and swelling or catching, if your knee's getting stuck, that's when surgery becomes an option for these. So I'm going to show you a really great study that just came out not too long ago. They compared doing physical therapy alone to having an arthroscopic surgery. And these people had a wide variety of meniscus tears, some large and some small. So the people who went straight to surgery just did surgery. The people who went to physical therapy were participating in 2 to 3 months. And all they did, this wasn't therapy in the way that we practice. This was just coming to therapy and exercising. No hands-on and no modalities were used, just exercise by itself. They exercised for about an hour, 2 to 3 days a week, and then the days that they didn't come to therapy, they did a few simple home exercises. The group that got therapy had a 16% stronger quad, and they were at 6 months and at 12 months down the road at the exact same level as the group that did surgery. So that extra trauma of surgery, the recovery after surgery, potentially missing work and medical costs and all of that could be avoided. And 6 to 12 months later, you can't tell any difference anyways. So I thought this was a pretty powerful study because exercise by itself is by no means physical therapy. And that's something that I'll talk a little bit more about here in just a moment. But it's a very promising study that shows that exercise by itself is really effective, and we know that exercise with all of the other stuff is even more effective. So first line of defense is come and work on strengthening that knee. The more that you strengthen the muscles surrounding the knee, the less reliant that femur becomes on pushing down on the tibia. So if you imagine the knee opening up a little bit and having more space, then that tear doesn't become so important. Okay? Does anybody have meniscus tears? Yeah, big group. So it is definitely physical therapy territory. So I don't want to bring you down if you already have a meniscus tear, but meniscus tears can lead to having knee osteoarthritis down the line. So osteoarthritis is characterized by the decrease in the articular cartilage that surrounds the joint. So imagine we have those menisci inside the knee. That's one type of cartilage. This articular cartilage is more like a second skin that surrounds the bottom of the bone. So again, it's shiny and it helps things slide, but this is also the protection that your bone has nerve endings, the cartilage doesn't. So if you imagine this bone and this bone touching each other without the cartilage, those nerves are getting aggravated every single time they touch. So you can imagine why arthritis is so uncomfortable, because when this cartilage wears away, it doesn't grow back, and then there's exposed pieces of that bone that are touching. So if you have meniscus that may have been torn in the past, you may grow some bone spurs and have degeneration of that articular cartilage. And by the way, this is the femur and the tibia, but this can also happen on the back side of the patella that makes contact with this little ridge right here. So you can have osteoarthritis that happens behind the patella as well. Arthritis is very prevalent. It's about a third of the folks over 63, and you experience pain when you wake up in the morning. It may be characterized as stiffness and not so much pain at first, and then as things progress, the pain may come in. Generally, people will say, it takes me about an hour or so every morning to get up and get moving, and then I do okay. And then the longer that I'm on my knee throughout the day, the more it starts to ache in the evening. So that's a really typical pattern, 24-hour pattern of somebody that has knee arthritis. And they may say, it's hard for me to raise up from a chair. It's hard for me to stand for too long. It hurts when I walk. It hurts when I try to climb stairs. Also, it might hurt to squat or kneel, or it might be impossible to squat or kneel with knee arthritis. Knee osteoarthritis is something that can lead to requiring a total knee replacement. But there is a lot of promising results that are showing that we can postpone the need for a knee replacement and also give better outcomes for when you do decide to go in for surgery. Having therapy beforehand can help you out with that. So we're going to do another study here. This study was a little bit more up my alley with the way that I like to practice. The PT involved more than just exercise. So the arthritis patients, the patients with knee arthritis had 8 weeks of physical therapy, and this consisted of manual therapy and strength exercises. Not quite the modalities yet, but at least some hands-on and some exercise together. So after the 2 months, they could walk 13% further in 6 minutes, which is a test. You time how far you walk in 6 minutes. And this is the big one. Their pain scores decreased by 56%. So this is one of the studies that got me really excited because it showed that the folks who were in the therapy group, only 5 out of 100 had knee replacement and in that 1 year. And in the non-PT group that just got a placebo, like fake ultrasound treatment, 20 out of 100 had knee replacement within a year. So significantly higher numbers of people who didn't do therapy decided to just, I need that knee replacement, get me in for surgery. So that's a huge deal. And what can we do? Here's a sample program. It consists of stretching exercises, range of motion exercises, and strengthening exercises. And this is just kind of a rough outline. Each person that comes in has something different. You know, some areas will be strong and some areas will be weak. But the therapist was selecting from this protocol for this particular study. And this is the part that I love. Not only did that person that came for therapy receive manual therapy to their knee, if they were evaluated and they were found to have spine, the lumbar spine, the hip, the ankle or foot problems at the same time as their evaluation for their knee was completed, they received manual therapy treatment consisting of stretching, range of motion, joint mobilization, and soft tissue massage techniques to those areas of the body as well. So I love this study because this is why we use such a broad approach with each of our patients. One cookie cutter exercise alone is not enough to give every person relief from their symptoms. So the lumbar spine, the hip, the knee, and the ankle and foot all being addressed were the reasons I think that this study showed such great outcomes. And we still haven't talked about the modalities. So we already talked about decreasing pain by decreasing inflammation, and we talked about manual therapy and strengthening, but we didn't talk about some of the ways that we can speed up this whole healing process. So some of those folks that have that mechanical pain where their kneecap isn't quite gliding right in the groove, we might use tape. We might use tape to pull the kneecap where it's supposed to go. We might use tape to try to get the quad muscle to engage better. There's all different kinds of taping, and there's different ways to put it on each person's knee that will be tailor fit to, of course, what's going on with that person. The other things that we use often are the modalities of ultrasound, which uses sound wave to bring blood flow in the area and sometimes can help us stretch out a tissue that's very tight. The cold laser, which cuts healing time in half. It's light therapy, and the great thing about laser is that we can use that on kids that have open growth plates, which we can't use ultrasound over the growth plate. And then iontophoresis, we can actually use a steroidal medication and use an electrical current to infuse that medicine up to 3 centimeters depth into the area. So you hear of people, I got a cortisone shot. Well, this is a way that you can do that without the invasiveness of doing a needle injection. So we do that treatment in the office, and the doctor just writes the prescription for the medicine that we apply with a patch and electricity. There's other modalities, and I invite you all to take a little peek on the way out that we have a little contest going on. So if you don't know some of these modalities, we can answer some of those questions, but the poster will show a picture of the modality, and then the answer sheet will have all the names, and you just have to pick which ones go with which. And there's massages in it for the winners. So there's a little sidebar there. But in general, all of these things are options that are going to be in the physical therapy plan of care for any one of these problems with the knee, from ligaments to the bursa, to the tendons and muscles, to the bone mechanics and cartilage. We would create a plan of care based on this. So I told you that I would mention a little bit about when you do decide to have surgery. So once PT has been tried, 2 to 3 days a week, 8 to 12 weeks worth of really working hard to try to get rid of this pain and inflammation, no improvement or feeling worse when you exercise, those are the kind of things that lead you down the road of surgery. But those 8 to 12 weeks will not be wasted. All the studies are showing that therapy before you have surgery leads to having better outcomes after the surgery. So don't ever feel like this is a waste of time, I need to just get the surgery done and get over with. That quad muscle that we talked about earlier shutting off, if you don't have that quad activated before you go into surgery, recovery afterwards is a nightmare. It takes a lot more work to get it kicked in again. So we focus on the quad, we focus on teaching you how to use crutches or a cane or a walker if you're going to need that after surgery. Sometimes a surgery is the first time you've ever been on an assistive device like that and you have no idea how to use it. My mom kept saying, oh, I can use the crutches. I said, please practice with me before you have surgery. No, I'll be fine. She fell twice after having, it was her foot, but we knocked down her confidence a few levels with that. But, practice with your therapist. Get in there, I'd rather you lose your balance with me right here to help you than when you're trying to climb the flight of stairs to go up to the bathroom or something in the middle of the night. So you become familiar with your exercise. You strengthen your arms, and of course, maybe you don't have to do 8 weeks post-op. Maybe you can get out of here in 5 if you do the therapy beforehand. And then the post-op, of course, if you have knee surgery, expect that you're going to need to come to therapy afterwards. And it varies because of the procedure. Like we talked about, ACL could be 6 months of therapy and even a year before you're back to doing what you want to do. But something like a meniscus tear, 8 weeks in with a small tear and a small arthroscopic surgery, you may be in and out of therapy a little bit quicker. But you would be functioning everything from just being able to walk, sitting up, standing up, then maybe running, cutting, all those kinds of things that you want to do. That's all part of the approach after therapy. And your wonderful therapist will be there along the way to hear you on your bad days and your good days and say, it's going to be okay. We're going to get you there. So that concludes my presentation about knee pain. I hope everybody has learned something and maybe been able to think a little bit more about your own knees and filled out your homework there. Did I miss anything? Did I answer all the questions? Did I answer all of your questions?
I have back problems also. So I don't know if my back is contributing to some of the issues that I have. I have osteoarthritis. On my right side, lately, when I'm ready to get up a few hours, instead I get up 2 hours ahead of time because I have the pain shooting down my right leg and on the outside. And I always thought the bursitis was on the right side that I'm feeling, bursa, but you're describing it inside my leg.
You may be thinking of a different bursa. There's a bursa up here,
Okay.
underneath your iliotibial band.
Yeah, that's where I have the pain.
Yeah. So you can feel iliotibial band bursa here and still have iliotibial band syndrome that causes pain on the outside of your knee as well. So the pain doesn't have to be right in that one spot, or it doesn't, it comes from a different area a lot of the times, especially if you feel that pathway shooting down the outside of the leg. Usually has to do with the IT band. Has a lot to do with back pain and hip strength and stability as well. Yes?
I remember the first slide you showed that pain can be also on top of the knee, but I
Yes.
didn't hear explanation about that. What would be the cause?
That's usually the quad muscle.
Quad muscle?
That's the muscle that we talked about shutting down. A lot of the strains of the quad muscle, where you overexert the muscle that's not strong enough, or even during a recovery from one of these other injuries, that you have this weak quad that you're asking to do too much. So you'll feel a lot of the pain on the top part of the knee from that. And sometimes the patella.
And if it's a sharp pain that suddenly it hurts for a second and it goes away and for weeks it disappears and it comes back, it's something that you would recommend treating or just...
Well, yeah, and that would probably be a weakness. That if you contract a muscle that's weak and it's almost on the verge of tearing, it kind of does this self-protective mechanism where you'll feel something sharp, and you can have maybe even a few micro tears with that sharp pain, and that's what you call, like a pulled muscle, degrees of a pulled muscle.
It won't heal itself.
It over time can actually get worse because it scars. As each time that you feel that sharp pain, you could be creating more inflammation and scar tissue, and then the muscle itself stays weak because you're not engaging it correctly as your body's protective mechanism. So you can see this vicious circle of pain, inflammation, weakness, pain, inflammation, more weakness, and you get that cycle. And then when the quad doesn't do its job, the patella doesn't slide up and down, and then you may have degeneration on the back of your patella, and then it kind of leads to the patellofemoral pain, and then that leads to arthritis. So it's kind of one of these catch it early, fix it while you can before it leads to worse problems. Pain is the body's warning light. Anyone else? Any questions? Okay. Well, like I said, I hope everybody learned anything. We have myself and three other of our therapists here this evening, and hopefully that they'll peek themselves out to wave and say hi. They're finishing up with some patients at the moment, but feel free to help yourself to some refreshments here and take your time. I'll be here for a little while. Thank you, everyone.
Thank you.